In this video, I'm going to discuss how the oncotic and hydrostatic pressures will determine the leakage of fluids out of the capillaries. So hydrostatic pressure is the force that pushes fluids out of the capillaries. Like for instance, high blood pressure will increase the hydrostatic pressure and thus push fluids out of the capillaries into the interstitial space. On the other hand, oncotic pressure is an osmotic pulling force that prevents leakage of fluids from the capillaries into the interstitial space. Now, to determine the net pressure of a leakage from the capillary into the interstitial space, you will have to subtract the hydrostatic pressure of the capillary from hydrostatic pressure of the tissue or interstitial fluid, and then minus the oncotic pressure of the capillary minus oncotic pressure of the tissue. And the higher the net pressure, the more leakage of the fluids from the capillaries into the interstitial space. Now, factors that affect the hydrostatic pressure include, for instance, hypertension or high blood pressure, and salt as well as water retention that is seen in patients with congestive heart failure or glomerulonephritis. And then condition that will decrease the oncotic pressure, as a consequence of which there would be increased net pressure, and so there would be fluid leakage from the capillaries into the interstitial space, include hypoalbuminemia, and conditions that cause hypoalbuminemia include, for instance, nephrotic syndrome, where there is more than 3.5 grams of protein excretion in the urine per day, as a consequence of which there would be low albumin, low oncotic pressure, and thus fluid will leak from the capillaries out into the interstitial space. Likewise, liver disease causes decreased production of the albumin, and then finally, Budd-Chiari syndrome, which is a malnutrition syndrome, is associated with low level of albumin. So these three conditions will cause hypoalbuminemia, as a consequence of which fluid will leak out into the interstitial space. While high blood pressure as well as salt and water retention from congestive heart failure or glomerulonephritis will do the same thing. They would cause leakage of fluid from the capillaries into the interstitial space, but it's through increased hydrostatic pressure, versus hypoalbuminemia that causes decreased oncotic pressure. So let me show you the equation one more time. So either increasing the hydrostatic pressures or decreasing the net oncotic pressures will cause increased net pressure for the leakage of fluid from capillaries out into the interstitial space. And then one other condition I would like to discuss with you is the liver disease, which can affect both the hydrostatic as well as the oncotic pressure. So what happens with the liver disease is that there could be low production of albumin, as a consequence of which there would be decreased oncotic pressure, and so fluid will now leak into the interstitial space. Alternatively, liver disease, like for instance cirrhosis, can cause obstruction of the vessels that are inside the liver, as a consequence of which it will cause portal hypertension. And so portal hypertension increases the hydrostatic pressure, and so again fluids will leak out into the interstitial space. So therefore, just keep in mind, with liver disease, it can affect both the oncotic pressure as well as the hydrostatic pressure via affecting the portal pressure. So portal hypertension can result from blockage of the vessels that are inside the liver itself, like for instance from liver cirrhosis. It can be from the extrahepatic blockage of the portal vein, which is before entering liver. So this is pre-hepatic obstruction that can cause portal hypertension. And then finally, Budd-Chiari syndrome causes post-hepatic obstruction of either the inferior vena cava or the hepatic veins. And conditions that can cause Budd-Chiari syndrome, for instance, include the hypercoagulation state, polycythemia vera, hepatocellular carcinoma, as well as pregnancy. So let me discuss different conditions that can lead to the portal hypertension in this image. So conditions that can cause intrahepatic obstruction of the livers, like for instance liver cirrhosis, can lead to the portal hypertension. Post-hepatic obstruction of either the inferior vena cava or hepatic vein, both of which can result from the Budd-Chiari syndrome can also lead to the portal hypertension, and then finally blockage of the portal vein that is right here can lead to the prehepatic obstruction and thus cause portal hypertension again. So therefore it could be intrahepatic, posthepatic, or prehepatic obstruction of the vessels to lead to the portal hypertension. Now, presentations of patients with portal hypertension include varicose hemorrhage. So since that now there is blockage of the portal veins, as a consequence of which there would be varicose, like esophageal varicose, that develop in these patients, and so now there is a risk of the rupture of these varicose and hemorrhage. So therefore, varicose hemorrhage can result from portal hypertension, as a consequence of which patients can present with hematemesis as well as melena. Patients can also present with ascites, where there is accumulation of fluid within the peritoneal cavity, and then as a complication of ascites, they can develop spontaneous bacterial peritonitis, where there is fever and extreme abdominal tenderness, and this condition can be treated with cefotaxime. Patients can also develop splenomegaly, so the splenic vein end up in the portal vein. And so if there is a blockage of the portal vein, therefore fluids will keep on accumulating in the spleen, as a consequence of which patients will develop splenomegaly. In addition, due to the hemodynamic changes that develop from the liver disease as well as cirrhosis, therefore kidney function can be affected and lead to the hepatorenal syndrome. There could also be pleural effusion, and then finally caput medusa as well as spider angiomata are potential complications of portal hypertension. So let me show you images of caput medusa as well as the spider angiomata. So with the caput medusa, what happens is that blood from the portal venous system will be shunted into the periumbilical veins, and so the periumbilical veins will be sticking out from the umbilical area. On the other hand, spider angiomata, which is shown in this image, can develop where there are spider telangiectasias that are most frequently seen in the face and the upper extremities. And then one question that I would like to ask you is that what is the underlying cause of the development of spider angiomata? So we just discussed that caput medusa is from the backflow of blood from the portal venous system into the periumbilical vein. With spider angiomata, it's not the blood flow that causes that. So what is the underlying cause of spider angiomata? And the reason for that is due to the alterations in the sex hormone metabolism. So for instance, from liver cirrhosis, there is alterations in the sex hormone metabolism, as a consequence of which patients can develop a spider angiomata. And there is actually evidence that male patients with spider angiomata have elevated levels of estrogen. And then for the same reason, spider angiomata can also be seen with the pregnancy. And then internal hemorrhoids is another complication that can arise from portal hypertension. So the superior rectal vein is part of the portal venous system, and thus due to the distension of the superior rectal veins, internal hemorrhoids can develop. Now, we just discussed earlier that caput medusa is also another complication of the portal hypertension due to the distension of the paraumbilical veins, and then esophageal varices can also develop because the left gastric vein is part of the portal venous system, and left gastric vein is connected to the esophageal vein, which is part of the systemic venous system. So due to the distension of the esophageal veins, esophageal varices can develop. So as a last point for this video, it's important for you to know that the superior rectal, paraumbilical, and the left gastric veins are part of the portal venous system, and thus due to the portal hypertension, hemorrhoids, internal hemorrhoids, caput medusa, as well as esophageal varices can develop. And then I just told you that left gastric is connected to the esophageal vein, superior rectal is connected to the middle and inferior rectal vein, while paraumbilical is connected to the superior and inferior epigastric veins. And so these veins are part of the systemic venous system, while the superior rectal, paraumbilical, and left gastric are part of the portal venous system. And that concludes our discussion of the portal hypertension.